Good evening, everyone. I'm Dr. Larry Newman, Chair of the American Migraine Foundation, as well as someone who lives with chronic migraine and also a parent of 2 kids living with chronic migraine. Like many of you attending tonight's program, I know the challenges faced when the people who you hold most dear struggle with the pain and disability caused by this invisible illness. I understand the struggles you face as you try to help your child navigate the complexities of living with this disease. I also know the hopes that you have at each visit when you're searching for answers, as well as the frustrations you can feel, either when the doctor doesn't seem to take your issues seriously or your child's issues seriously enough, downplays your concerns, or attributes all of your child's symptoms to either anxiety or stress. Like many of you, I too have been on this roller coaster ride of emotions, searching for answers, hoping for something that will offer our children relief from the pain and freedom from the stigma that this disease causes. For those reasons, and for many others, I have asked several of our pediatric migraine specialists to join us tonight to hear about their approaches and how they evaluate and treat children's headache disorders, as well as how they employ different strategies when the first, second, or however many attempts it takes that is necessary to try and come up with some helpful plan. Joining me tonight are 3 doctors, Dr. Amy Gelfand, who is a pediatric neurologist specializing in diagnosing and treating children with a variety of headache disorders. She's the director of the Child and Adolescent Headache Center at UCSF. She's also currently the editor-in-chief of our journal, Headache. We also have Dr. Kaitlin Greene, who is also a pediatric neurologist specializing in caring for children and adolescents with headache. Kaitlin is the director of the Child and Adolescent Headache Program, let's see if I can get this right, at the Dornbescher Children's Hospital at Oregon University and Science University in Portland. And we also have Dr. Serena Orr, another pediatric neurologist with a subspecialty in headache medicine. Dr. Orr is the director of the Pediatric Headache Program at the Alberta Children's Hospital in Calgary, Canada. And finally, besides having just an illustrious group of physicians, we've invited Jennifer Senne. Jennifer is our patient advocate this evening. She's a mother of 4 and a migraine advocate living with chronic migraine. And before any of us start talking about some of the cases at hand, I'm just going to ask Jennifer just to talk a little bit about her experiences that she's had navigating this patient journey, and hopefully to share some tips and hopefully her positive rather than her negative experiences during this navigation. Jennifer.
Hi, good evening. Well, good morning from Guam, but good evening to the rest of you. I'm glad to be here. My name is Jennifer Senne, and I was diagnosed with hemiplegic migraine in 2014. And actually, it's kind of been a roller coaster because sometimes it's kind of hard for me to figure out what's coming on because now I have had some more like of a chronic migraine. And I have 4 children, and 2 of those, my daughters, actually suffer from migraine as well. My daughter, Haley, who's now 21, started having her symptoms when she was about 16. And it wasn't very hard for me to help her through it just because I've experienced similar migraine symptoms, just the light sensitivity, nausea, and noise sensitivity and such. And so, I helped her treat her migraine symptoms, of course, along with her pediatrician at that point, with OTC, which is over-the-counter medication. But however, my youngest daughter was diagnosed with abdominal migraine when she was 9 years old. I had no clue what abdominal migraine was. And so that journey was a little bit different. For some reason, every time she would have her symptoms, it always starts with a stomach ache. And I've always kind of overlooked migraine because I've always thought migraine, headache and such. And So every time she would have her symptoms and would complain, my help for her was delayed. The treatment, I wasn't proactive, I suppose, with giving her the proper medication at that point, just because it didn't dawn on me that it was migraine, just because it always started with her stomach. And so it happened several times where she would always complain with her stomach problems. And so finally I took her to a pediatrician. And like I said, she was diagnosed with abdominal migraine. And I was pretty surprised because like I said, I never thought migraine could start in your stomach. Then later on, I think as she got older, her symptoms kind of shifted. She kind of, I guess her abdominal pain was less pronounced, but then she started having more headaches and started having nausea. And of course, as she got older, she was able to explain to me more what she was feeling, as opposed to when she was younger, to where I was having to guess what she was feeling, because that was more of the challenge for me. Like, she couldn't express her feelings of, my stomach hurts, it just doesn't feel right. And then later on, she would tell me, Mommy, my head hurts. And it was a little bit too late for me then to kind of help her out with, her treatment. But as she got older, I was able to kind of see the patterns of the symptoms of, and then what to watch for. She would squint her eyes and then, get nauseated. And I just watch her, because even then, because I would correlate it sometimes with her hormones, her menstrual cramps. And I would say, oh, that's just your menstrual cramps, so don't worry about it, relax and stuff. And then later on, I'd look at her and I'm like, oh no, I think this is migraine coming on. So I think that was the challenge for me. And based on my experience, I think paying attention to those subtle symptoms and talking to your pediatrician and your neurologist to just be familiar of what to watch for. And as they grew older, I was able to explain to them, because even she still misses it. She's 19 now, and sometimes she still misses her the symptoms, that when it comes on, she still correlate it with the monthly hormonal changes, because it kind of overlap with each other. And so I try to kind of like remind her, that you got to watch out for the symptoms and you need to catch it early. And so I think for patients or parents out there that have little children or, even teenager, is just to kind of watch for those symptoms, the subtle symptoms, I suppose, and to make sure that, you explain it to your children to let them know what to tell you as a parent. And, and then talk to your neurologist and your doctor and see what you guys can do together.
Great. Thanks, Jennifer. That's a really good jumping off point. And it teaches us all how it takes a village. It's not just the patient, it's not just the doctor, it's the family. And unless everybody is engaged, you're not going to get the best outcome. And I'm going to come back to you, because I put some patient summaries. It's an amalgam of different patients. They're not actual patients, but lots of patients lumped into these that I'm going to ask our experts to talk about. And then I'll ask you, possibly along the line, to critique if this is what you've experienced and if you wish it was done this way when you first came there. So, Dr. Gelfand, are you still there?
I am here.
All right, good. All right. So to the audience who can't see Dr. Gelfand, she's also joining us, but she's having a camera problem. So here's our first patient, and I'm going to ask everybody to give some opinions. So our first patient is Amanda, and Amanda is 11 years old, and she tells us she's been having attacks of headaches for about the past 2 years or so. She also, and her parents tell us, that these attacks are becoming more frequent. They're also more severe over the past year. On several occasions over the last few months, Amanda was either unable to go to school, or if she did go to school, she had to leave school early. Her parents tell you that they've had Amanda evaluated by her pediatrician, who said, well, everything looks good. Maybe you should take her to the eye doctor, and then to the allergist, and then to the dentist if you can't find anything. they did, as any good parent, they took Amanda to all those different doctors, and all of those specialists said, everything's normal, don't worry about it, she's fine, which is not helping Amanda any because she's still having these frequent headaches. The pediatrician then recommended, since everything was normal, that maybe Amanda's parents should take Amanda to see a psychologist. And why was this? Well, maybe she's stressed because it seems that her headaches always seem to strike on Monday mornings. So I think this is a good jumping off point. And Dr. Gelfand, I'll start with you and sitting there in the dark. If you can just tell us a little bit about, how common is headache and migraine in young children? And since many parents of children with migraine have migraine themselves, are there differences in the way these headaches look if you're a young child versus an adult?
Yes, thank you so much. And I'm so glad we're doing this because the stigma that is rampant around migraine is just dripping from a number of things in that case. But certainly migraine is very common in children and adolescents. The prevalence of migraine is about 5% by age 10, so about Amanda's age. And I like to say that that means that by the time kids are in 4th or 5th grade, there's a child with migraine in essentially every classroom. So it is a very common disease in children, and the prevalence just increases from there. So as kids go through puberty, the prevalence of migraine is higher, and before puberty, boys and girls are equally likely to be affected, but as they go through puberty, it's more girls than boys, coming to that adult prevalence difference that we see of about 3 to 1. There are some ways that migraine can look different in kids. And I think Jennifer touched on this with abdominal migraine. That's something we see more in kids for sure. But in terms of migraine headaches, they can also look different. They can be shorter in younger children than they are in older children or adults. And the pain is more likely to be bilateral than unilateral. I think it's also really interesting, this question about why her attacks are happening on Mondays. And that might make somebody, I guess I see where somebody was wondering if it was something about school, but there's a really interesting study where people self-reported their migraine attacks. And it turns out that Monday is the most migrainous day of the week. And I think that the reason for that is that people who have migraine, they're more sensitive to change, and that includes change in sleep schedules. And after a weekend of doing whatever you're doing, maybe sleeping in, maybe staying up later, Sunday night, maybe it's hard to get to sleep, and then having to sort of jerk back into the regular schedule on Monday morning might mean that she didn't get very much sleep on Sunday night, or at least there was a change in her sleep schedule. And so I think there's a lot of reasons why Monday might be the day that the brain is most susceptible to a migraine attack that don't necessarily have anything to do with, well, stress is a loaded word and a complex word, but just has to do with, I think, change in her sleep schedule.
Okay, great overview. Let me just ask you to clarify something, since we have a patient-centered audience here. You said sometimes the headaches are more likely to be bilateral than unilateral. What does bilateral versus unilateral mean?
Thank you. Yes. So in kids and adolescents, the pain of migraine headaches tends to be on both sides of the head, whereas in adults, they might experience pain that's just on one side of the head.
Right. So building on that, Dr. Orr, often in an adult practice that I have, our patients who are referred to us, if they have headaches on both sides of their head, almost invariably the referring doctor says, must be stress, must be a tension headache. What's a tension headache, and how do you distinguish it from a migraine?
Hi, can you hear me?
Yep.
So yeah, tension headaches tend to be headaches that have a wider range of duration. They tend to affect kind of more the whole head and have a more pressure-like sensation. So contrasting that with migraine, Typically with migraine in children, although we see on both sides, it's usually kind of front and on the sides as opposed to all over the head, so still more localized. And we also see a difference in terms of the symptoms that go along. So with migraine, you tend to have sensitivity to light, which in younger kids might look like the child wanting to go to their room and close the blinds. Sensitivity to sound, the child may want to avoid loud noises, turn off the TV close by. And in migraine, you also have more commonly nausea and vomiting, whereas in tension-type headache, there isn't nausea or vomiting, and typically there isn't both sensitivity to light and sound, which we can see in migraine. So the other difference between the two is in the severity of the pain. So with migraine, we typically think of it as a higher severity pain. We say moderate, so in the middle, or severe, so higher severity, versus tension-type headache tends to be more mild or moderate, so lower severity. And then we look at the functional impairment as well. Typically, there's much more impact on the day-to-day activities with migraine compared to tension headache.
Great, thanks. That's a great description of the two. So Dr. Greene, just picking up on poor Amanda. You know, Amanda's pediatrician said it might be stress. And how do you distinguish a cause from a trigger? What exactly, when a doctor talks to the patient and the family member and says, you know, I want you to look for certain triggers. How does a trigger differ from a cause, and what are the common triggers you see?
This is such an important question, and one that comes up all the time in our practice, because stress, as Dr. Gelfand said, is kind of a loaded word. It often is a scapegoat for the cause of migraines. But when we think about the cause, particularly of migraine, we know now that migraine is probably a genetic type of headache disorder. It's caused by differences or inherited differences in the way the brain processes pain, particularly certain pain signaling molecules. And so stress doesn't actually cause that difference in pain signaling. However, when we think about things that trigger migraine attacks, we think about circumstances or experiences that might make it more likely for a migraine to happen. So things that might set off that abnormal pain signaling pathway and cause a headache. I think stress is probably one of the most commonly identified triggers for migraine, meaning having a stressful experience or being under stress can make it more likely for you to have a migraine attack. Other things that come up as triggers for headache include things like changes in sleep pattern, as Dr. Gelfand was talking about, related to Monday morning headaches. Also changes in hydration status, inconsistent meal times, anything that contributes to sort of change in the body's homeostasis or set point can be a trigger.
Great. So we need to stop assigning blame to all the headaches. Why do you think you got the headache? You didn't drink enough water. Are you stressed? You didn't exercise enough today. It's not the person's fault that they had it's their brain's fault or their genetic fault. It's their genetic. So Jennifer, just listening to this, before I ask the doctors to give their opinions on Amanda and how they might reach out and treat her, is this the kind of experience you noted when you first brought your children to the pediatrician or the neurologist?
Oh yes, definitely. At first, I think it would be more with Haley when I first took her to her pediatrician. The questions were, how stressed are you in school, and have you had any, I guess, stressful event? And I mean, she was very active in sports and such, and so that was a lot of the question. And then later on, they figured out that it wasn't just stress that was causing it, because she would tell the doctor that sometimes during her I guess her monthly hormonal changes, that causes a lot of her migraine as well. And sometimes even during when she's not in her menstrual cycle, she would still have some of the trigger, and we found out that sometimes it's because she stays up a lot at night to study as well. So
great.
Yeah, so I've seen those and I've heard similar.
So thank you. So let's get back to Amanda. So Amanda's parents are looking for answers. Poor Amanda is either going to school late if she's or missing school and leaving early. She goes to the school nurse, and the nurse is not really sure what to do, so they give Amanda an ice pack until her mom comes to pick her up. I'm sure we can do better than that for Amanda. Dr. Gelfand, what would you start with in an 11-year-old with these kind of headaches?
We can definitely do better than that for Amanda. I think that first line for acute treatment, meaning as needed in the moment treatment, we would probably start with an NSAID medicine, something like ibuprofen, which is Motrin or Advil. If that's not effective, then we'd be moving on to a migraine-specific medication, a triptan medicine most often, and maybe even using both of them together. For her, she's 11, so rizatriptan, which is Maxalt, is FDA labeled for use in her age group, and we certainly would be sometimes using medications off-label in her age group as well. So there are other triptans that we might use too. But I think the usual starting point would be adequately dosed, typical NSAID like ibuprofen. And if that's not adequate, moving on quickly to a migraine-specific medication, a triptan, and possibly the combination of the two if needed.
Gotcha. Okay. Anybody, Dr. Greene, Dr. Orr, do you have anything to add to that?
No, I agree. I think we're going to talk later about when there's a lot of vomiting and whatnot and what to do in that situation. So.
Okay. Well, that leads me to that one then, since you just you just led me by the nose to that one. All right, so let's talk about Tamara, our second patient. Tamara's a little bit older. Tamara's 19 years old, but you're seeing her for the first time. And she'd been seeing her pediatrician, like Amanda had, for many years, up until this visit with you. She describes attacks of severe headaches that are associated with nausea and vomiting that began just last year. She also tells you that these headaches are scary because before the headaches develop, she notices there's changes in her vision. She sees flashing lights and she sees zigzag lines, and they can last up to 40 minutes at a time. Her pediatrician said, well, maybe, in a very nice way, well, maybe this is a brain tumor, so let's get an MRI of your brain. And the MRI done after that first visual episode was completely normal, luckily. But Tamara and her parents tell you that they're there now because attacks are now occurring once, sometimes twice every month. The pediatrician suggested Advil, the NSAID, the non-steroidal anti-inflammatory that Dr. Gelfand alluded to, didn't work. He then gave her a combination medication containing butalbital, caffeine, and acetaminophen, which is also called Furoset. That doesn't help. It just makes her really stupid and she can't study when she takes it. And her mom says she's in danger of failing one, maybe even 2 classes this semester. Her mother and her older sister also live with migraine, so they have migraine running in the family. Tamara tried her mother's almotriptan, one of those migraine-specific triptans, which didn't help, but she thinks it didn't help because as soon as she took it, she got sick and vomited it back up. She takes no other medications whatsoever, and mom and dad are really worried that how is she going to go to college and stay in college and have a life after this if she's bedbound and has nothing to do. So I'll start with you, Dr. Orr. How do you treat migraine when someone has nausea and vomiting, especially if they can't keep their pills down?
Yeah, so this is definitely a really important thing for doctors to ask is there vomiting and how early is it during the attack? Because that really does impact the treatment decisions that we'll make. And so when there's a lot of vomiting and when it's early enough that the child is going to be throwing up a swallowed medication, we do look at alternate routes of delivery for the medication. So whether that's a spray into the nose, there's a couple of triptans that have what we call intranasal sprays, an oral dissolving tablet that you just place on the tongue and dissolves. And there's even powder formulations that can be mixed into water and kind of taken with a faster onset and without that risk of vomiting up a pill. So the advantage of those delivery systems is avoiding vomiting up the pill and then more rapid onset because it bypasses the need to go all the way down all the tubes and into the stomach and then get absorbed through the gut and gets absorbed more rapidly through the nose or in the mouth. The other thing to consider, so we have triptans with those deliveries. There's also an NSAID that is a powder formulation. And the other thing to consider is sometimes having an NSAID plus or minus a triptan, those migraine-specific medicines we were talking about, may not be enough to manage the nausea and vomiting. And so sometimes we actually look at adding an anti-nausea medication on top of those just to deal with the excessive nausea and vomiting. So all those types of medications may not be dealing with the underlying brain problem that we see in migraine. The suppression of the nausea and vomiting sometimes is really important. So we look at medications like ondansetron or Zofran, for example, that comes in a dissolving tablet. Sometimes we look at pill medications like metoclopramide or prochlorperazine that come in swallowed pills. One of them has a rectal formulation and they come in IV as well if the child ends up having to go to the emergency department. So those are important considerations when there's a lot of nausea and vomiting with the attacks.
It's also, as you pointed out, it's also important for the doctor to ask if nausea and vomiting are present because lots of times the patients are too shy to discuss it.
Exactly.
Dr. Greene, so Tamara reported this scary episode that her pediatrician attributed to a brain tumor, which luckily was incorrect. What was that, and what would you call it, and what do you do about it?
That type of visual symptom that occurs reliably with migraine-like headaches, we would probably call a migraine aura. So an aura is a transient neurologic symptom or a symptom that comes and goes, typically in association with a migraine headache attack. The most common type of an aura is a visual aura, and it's classically described as either a patch of vision that you can't see or sometimes jagged, colorful lines that patients see, often just in one part of their vision. But it can often either get bigger or smaller over time or travel across the visual field. In addition to visual aura, patients can sometimes have changes in sensation related to their migraine attacks, which we call sensory aura. That can be a sensation of numbness or pins and needles, classically starting in the fingertips or toes and then gradually spreading up into the arms or legs. Patients can also have speech changes with their migraine. And then less common types of aura include hemiplegic migraine, which Jennifer was telling us about, when migraine attacks are associated with weakness or inability to move half of the body. And then brainstem aura, which is symptoms of vertigo or dizziness, ringing in the ear, slurring of the speech, imbalance, or changes in hearing that can happen with a migraine attack. Migraine affects probably about a quarter to a fifth of patients who get migraine. So it's not everybody who has migraine. You can have migraine with or without aura. And it doesn't change all that much about how we treat migraine, but there's some important considerations that we think about with counseling. One is that women who have migraine with aura are at an increased risk of having stroke across the lifespan, and that seems to be higher in patients who also smoke cigarettes or use estrogen-containing medications, particularly medications that have high amounts of estrogen. So if a patient is needing to be on, for example, oral contraceptive pills, we usually counsel around using oral contraceptive pills that contain high amounts of estrogen just to help minimize that risk of stroke. The other thing that's worth noting about migraine with aura is that triptan medications, those migraine-specific as-needed medications, are technically contraindicated or shouldn't be used in patients who have hemiplegic migraine or migraine with brainstem aura. But in some cases, we do consider them, and it's worth talking with your doctor about whether that would be a consideration in your case.
Great, thanks. So Dr. Gelfand, Tamara is 19 years old. She's in college. She's there in the room with her parents, and she tells us she's on no medications. Are you going to take her at her word? And if not, how do you address that?
So that's a good question. She's she's certainly of age to give her own healthcare information, but even if she were under 18, that would still be the case for an adolescent. And I think whenever I see a teenage patient, I like to do part of the visit where it's just us one-on-one, talking about what else might be going on in their health overall. I start out that part of the visit saying, is there anything else about your health that you think that I should know? And then from there, I ask more specific questions um, about a number of topics, but including any other medications that maybe they want to share or any other substances that may be something that they utilize. So I think there's information to be gleaned in a more private setting whenever talking with anyone in the adolescent age range.
Great. So when you asked her this question, Tamara tells you, I don't want my parents to know, but I've been on the birth control pill. I got it from the student health center. Is there an issue with the birth control pill and Tamara since she has aura?
That's a really good question. And sorry if you're hearing background piano music. My son has decided it's a great time to play the piano. So since she's a young woman with migraine with aura, and as Dr. Greene mentioned, there is an increased risk of stroke in young women with migraine with aura. However, the absolute risk, the likelihood is very low still because the risk of stroke in young women is overall low. And so the way that I approach this, and different doctors are probably going to be different on this, is that I think that having migraine with aura is not an absolute contraindication to using a birth control pill. There's a lot of reasons that somebody might need to be on a birth control pill, whether it's avoiding pregnancy, heavy periods, cramps, whatever it is. And certainly pregnancy is a risk for stroke in and of itself. So everything in medicine is a risk to benefit ratio calculation. So I don't think of this as an absolute contraindication to using a birth control pill. I just say to try to use the formulation that has the lowest amount of estrogen possible, that meets the need that you have. Ideally 20 micrograms of estradiol or less per day.
Great. I also brought that up for the audience. So just because we ask about medication, it doesn't have to be a prescription medication. So birth control pill is clearly a prescription medication, but your doctors and your kids' doctors should know about vitamins and supplements and other things they may be taking that may interact with something that we may want to prescribe. So that's why we would try to bring it up. All right, see, we have time for maybe one more, maybe if we speak quickly, maybe more than one. I'm going to talk about Robert. So Robert is 16 years old, and he's seen lots of doctors before he's seen you. You're about the 6th or 7th doctor. He reports that, like both of his parents, he's been having severe attacks of migraine that have been increasing in both frequency and severity over the last year. He tells you that he's got some really bad attacks, about 3 to 4 times, and less severe attacks that occur even more often than that, although they don't all look like his migraines. Sometimes they feel like migraines and he's disabled, and other times he can push through. His last doctor told him that he has migraine and he has tension type headache, and that he needs to drink more water and he needs to relax more, and his headaches will get better. When the headaches are bad, he takes sumatriptan. But he's always worried that he's going to run out of sumatriptan because his insurance only gives him 3 or 4 for the month. So he hoards them to make sure that if he gets a bad headache at the end of the month, he still has medications, and he suffers more often at the beginning of the month. If you ask how many headaches he has, Robert says, I get about 3 or 4 migraines a month. Is there any more information you want to know to get the real history from Robert, to get the real number? So Dr. Orr, we'll start with you.
Yeah, so I think this is interesting actually, because a lot of my patients will fill out headache questionnaires before the visit electronically. And I always verify everything that's in it, in particular the questions around headache frequency. So often if you ask a child or an adolescent how many headaches are you having in a week or a month, they're only going to tell you about the ones where they're really disabled. And so it's always, I kind of always ask and follow up, tell me about all of the headaches, even the little ones, because we count those as well. in particular because migraine is a spectrum. And so you see a lot of kids coming in with this dual tension type chronic migraine diagnosis, but really in the situation where there's really frequent headaches and the underlying diagnosis is migraine, some may look more like tension type headache because they're less severe, but it's because the severity of the attacks and the disease of migraine is on a spectrum. So I would be asking specifically for all of the headaches, even the ones that seem less disabling, how many are there in a week or in a month? And then how many of those are the more severe attacks where there's a lot of disability, to try to get a sense of the big picture and the more disabling attacks.
Right. So Dr. Gelfand, so Dr. Orr found out that Robert's having about 17, 18 headaches. When asked how many days do you not have headaches, there's hardly any. He has about 18 to 20 headache days a month. So how would you classify that type of migraine? And is that treatment different than people who just have intermittent, infrequent headaches?
So I think about diagnosing the condition that the person has rather than each individual headache. And at this frequency, which is more than 15 days per month of headaches, I would say that Robert has chronic migraine, which is the diagnosis that we'd give whenever there's at least 15 days of headache for at least the last 3 months. And technically, at least ideally 8 of them having features of migraine or responding to migraine specific medicine. And when I think about treating chronic migraine, I don't necessarily think dramatically differently about the approach, but I'm really going to emphasize more or just particularly emphasize our preventive approach, because the fundamental problem here is there's too many headache days. And so we might want to think also in detail about the acute treatment plan, but we really need to get the frequency of headache days down and the frequency of severe headache days down. And so my job and my focus is going to be on what do I think are the most effective strategies to get that frequency down.
Okay. So, Dr. Greene, you're a little curious. He tells you that he either pushes through his headaches or he takes sumatriptan, he only gets 4, but he's getting 18, 20 headaches a month. What do you think he's doing for the other days? And is it important to find out what he's doing on those other days?
Yes, definitely. So I think just like patients often tell us about their more severe migraine attacks, they also usually tell us about which prescription medications they're using for migraine, both for prevention of migraine, but also for as needed treatment. So I always ask specifically about use of other over-the-counter medications like ibuprofen, Tylenol or acetaminophen, Excedrin, naproxen or Aleve. And it's important to know, I think, first, because I like to know whether the treatments that patients are using are helping them or not. If it's not helping, it's time to talk about a different option for headache treatment. And then we also know that certain as needed medications, including over-the-counter pain medications like ibuprofen and acetaminophen, do seem to be associated with increased risk of developing chronic migraine when they're used in excess. So using over-the-counter medications like acetaminophen or ibuprofen more than 15 days per month seems to be associated with an increased risk of chronic migraine, although that can be really tricky to navigate because it's also the case that patients are having frequent headaches and we don't want to tell them not to treat their headaches. And so emphasizing the importance of prevention to decrease headache frequency while also trying to decrease how often they're needing to take as needed medications is important.
Right. Thank you. So Dr. Orr, building on what Dr. Greene just said, Robert, when asked, doesn't tell us because it's an over-the-counter medication, but he's actually taking Excedrin, 2 tablets, once to twice a day, at least 4 days every week. And he's been doing that now for close to a year. Make believe Robert's a little bit different. You're the 5th doctor he's seen. He's now tried 6 or 7 different preventive medications, and none of them have worked. Do you think there's a reason why those medications may not have worked? Now getting the rest of the story?
Yeah, I mean, it sounds like he meets criteria for what we call medication overuse headache. So like Dr. Greene was talking about, overuse of NSAIDs, medications on that kind of over-the-counter spectrum for more than 3 days a week or 15 days a month, consistently for at least 3 months, can lead to what we think medication overuse headache. There's actually a really interesting study that was done by my mentor in Cincinnati that looked at changes in gene expression in the brain in children with chronic migraine and medication overuse headache, and those with chronic migraine without medication overuse headache. And they found that those who were overusing medication had changes in gene expression in a variety of brain areas that then kind of reverted back to a more typical pattern after 6 weeks of washing out the overused medication. And there's other data kind of looking at neuroimaging and basic science data to show that the overuse of medication can cause changes in the brain that makes the brain better at giving people pain. And so when there's medication overuse, we definitely consider, this is a controversial topic, but in my practice, I consider a washout of the overused medication in combination with consideration for preventative medication, because without trying to reverse all of those changes that have happened related to the medication overuse, it can be more of an uphill battle to find a preventive medication that's effective. It is controversial. There's debate in the field about what's best to do and whether to do a washout or a slow wean or whether we even need to do that. But the small amount of pediatric studies that we have on medication overuse suggests that a washout can be really effective. And by that, I mean stopping the overused medication for 6 weeks or so.
Exactly. Thank you. So we're just about at time. I want to thank Drs. Gelfand, Greene, and Orr. I'm going to leave the last word to Ms. Senne, but before I do, the topic was why my child's treatment plan isn't working, and hopefully you've seen there's several reasons. There may be medication overuse that hasn't been identified. Perhaps your child has been misdiagnosed. Maybe they're having migraine and not tension type headache, and it shouldn't all be blamed on stress. Perhaps their acute medication isn't working because there's nausea or vomiting or because it's not a specific medication. So there's plenty of reasons. I think we need to do more of these to get more of the other issues out. But with the last minute or two, Jennifer, I'm going to ask you, let us hear the positives of navigating this journey.
I would say just because I struggle with migraine as well, that I was able to kind of pay closer attention to my children and the things that they need. And I was pretty surprised that there were other things that I could have done. Listening to all the neurologists today, that there was some other things that I could have done. But I think the positive is that there's help out there. To the parents, don't lose hope. It's just, I know it's hard to watch children suffer, but as long as we're diligent in helping and diligent in seeking help, I think that it would help us in managing and navigating this journey together. And like Dr. Newman said, it takes a village to take care of our children. So.
Thank you all. Thanks to the panel. And for more information, you can always check out AmericanMigraineFoundation.org for a wealth of information, both for children and adults. Good night, everybody.